welcome you to another Sovah Health CME program this evening. The program this evening will provide 1.5 hours of Category 1 Physician CME credit and 1.5 hours of the Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern State CME Collaborative to provide Category 1 Physicians AMA CME to physicians. Similarly, we're accredited by the Virginia Nurses Association to provide nursing CE credit for our programs. The program this evening was developed to promote two desirable physician attributes, that being patient-centered care and professionalism. The need assessment to have the program this evening came from our annual CME needs assessment survey that we do each year. Mr. Lewis, myself, and members of the Sovah Health CME committee have nothing to disclose as far as any commercial relationships. There is no commercial support for the program this evening. Instead, it, like all of our Category 1 CME programs, is supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation here in Danville. Dr. Landis, who founded the Southside Urology Clinic, previously known as the Danville Urology Clinic, made a sizable donation to develop an education program for healthcare professionals in our community. And through that grant and its subsequent growth, we've been able to bring you programs such as the one we're going to have this evening. After the program this evening, you'll receive an email and an evaluation form. It contains 7 or more questions or requests from you. I always like to remind everyone that I think the 4th question is, what will you change in your practice based on what you learned this evening? That is for everyone, not just for the physicians. We all practice our craft within our scope of practice. So take a few minutes and give us your thoughtful responses to the questions. We use these evaluations extensively to promote and to develop our programs. When you receive that eval form, it will ask you to re-enter your name and your email address, etc. Please give us your full name. The name you give us is what ends up on the CME certificate for your attendance that you will receive. So no nicknames or short names. Give us the full name. If someone is with you listening to the program this evening, for which they are more than welcome, we're delighted to have everyone attend who has an interest. Please let myself, Mary, or Jennifer know about that so we can be sure that person receives credit for attendance also. Mary will put into the chat box at the end of the program a QR code you can click on to get the eval form and complete it if you like that approach better. I do know that Mr. Lewis will be encouraging questions and comments throughout the evening. We also like to remind the residents on the call that you do not need to collect your CME certificates when they are sent to you. Your coordinators, Dara Johnson and Lori Galvez, maintain a record of your attendance to these programs as far as what your program is requiring of you. The evaluation forms are not required of physicians who attend to receive credit, but the Virginia Nurses Association does require nurses and nurse practitioners to complete an evaluation form before you can receive your CE credits. If anyone has any questions about the eval process or follow-up information about the program, please feel free to email or call either myself, Mary Kent, or Jennifer Goodman. As I mentioned earlier, questions are encouraged. If you ask a question or have a comment, once you finish, please mute your phone so we don't get feedback. I know Mr. Lewis encourages any and all questions and comments, and that process actually enriches the overall program. Finally, I'd like to highlight a couple of programs that will be coming up in the next few weeks. Next week, next Thursday evening, October 16th, we are delighted to have Dr. Stephen Frank from the Johns Hopkins Hospital in Baltimore review for us evidence-based best use of blood products. Dr. Frank is an international expert on the appropriate use of blood products and its replacement, both the indications and the actual mechanics of doing that. We're also pleased that our new Chief Medical Officer, Dr. Cornell Cooper, will be moderating that program, and it'll give you a chance to meet Dr. Cooper, who's just an excellent physician also. So I hope you'll be able to attend that. The week after that, October 23rd, we'll have an update on osteoporosis diagnosis and management by Dr. Robert or Bob Adler. Dr. Adler is the bone specialist for a number of years at the Central Virginia Veterans Affairs Hospital. That is part of the Virginia Commonwealth University in Richmond. He's a great talker, a nice, really good teacher. And if you have interest in bone disease, its prevention and management in the general population, I think you'll enjoy that. I don't have a slide to show you this evening, but we have another program that will be presenting within the next 2 to 3 weeks. Dr. Allison Baracco, who is the medical director for the Virginia Department of Health in the western part of our state, is going to provide us an update on the current Virginia Department of Health VDH recommendations for the vaccines. There's been lots of controversy, if you will, in the popular press about this, and she'll be on and do a program that'll review what in Virginia are the expectations and recommendations. We'll send out a notice about that as soon as we get that date confirmed with her, but it will be within the next 2 to 3 weeks. So that leads me to the great opportunity to introduce to those of you who have not yet attended a program that Mr. Neil Lewis has done for us. This, I believe, will be his third in a series. We ask him to come roughly about every 18 months to talk with us about new Virginia legislation regarding medical malpractice and to give us insight into those conditions that have led to concerns, to suits, in the way that we can learn from that and help prevent these occurrences in the future. Mr. Lewis is a very noted lawyer and academic attorney. He began his educational journey at the University of Houston, where he received his undergraduate degree and did that with honors. He went on to get his law degree from the University of Richmond, where he graduated magna cum laude. He was notable in his work in law school, being the editor-in-chief of the Richmond Journal of Law and Review. He also was a member of the Honor Court Justice Group and was a teaching assistant on specifically legal skills regarding medical malpractice. During his educational journey, he also spent time in the U.S. Navy, where he became a nuclear power school engineering lab technician. And then he currently has been for a number of years a partner in the Hancock Daniel law firm. For those of you who may not be familiar with Hancock Daniel, it is a premier medical malpractice defense attorney and one in which has worked with Sovah Health and previously Denver Regional Medical Center very constructively. We're very grateful to have him and his associates help with the issues that arise here. And then finally, he's received yet another notable award and recognition. He has received the award for the Article of the Year for the Virginia Association of Defense Attorneys. So with all that being said, Mr. Lewis, we're delighted to have you. If you will bring up your slides, it will knock mine off, and we are ready to go. Thanks so much.
Great. Thank you for that introduction. Let's get my sharing started and start my slides, and we will go to town here. 1 second. There we go. Okay.
Let's go.
Miriam, excellent. Once again, my name is Neil Lewis. I am a medical malpractice defense attorney, and I practice with the law firm of Hancock Daniel. One of the most challenging aspects of handling presentations like this is that I do not have a sea of people to look out upon. And that results in some frustration. I'm a litigator. Being in front of a jury is what I do. Even when there's no jury and it's just the judge, I can see him or her frowning at me and clearly disagreeing with what I'm saying. And as a result, I can't tell what is going on. So I apologize in advance if at times I don't connect as well as I do in front of a jury. Thanks for coming to today's presentation. We're going to talk about really three things. We're going to talk about some recent verdict and settlement information in Virginia, some recent changes in Virginia law that I think are particularly important, dealing with the medical malpractice cap, as well as the article that I recently wrote on something called respondeat superior, which we'll get into later. It means the employer is responsible for the employee, basically. We'll talk just briefly about artificial intelligence. I know that everyone is exhausted about hearing how artificial intelligence is going to change, but I just want to take a little bit of a peek on some potential liability issues and liability areas in that field. And then lastly, we'll field some questions. Most importantly, though, I have to start with my disclaimer, and my disclaimer is here. Ladies and gentlemen, nothing today that I say today constitutes legal advice. If you require formal legal assistance, please consult your own attorney. Once again, thank you very much. Okay, why do I say that? Why do I bring that up? That actually turns back to an issue that I encounter in many of my cases, which is the curbside consult. That informal discussion that happens between two providers. Hey, what do you think about condition A or condition B? That ultimately another provider ends up documenting in the record. Of course, he documents that I asked Dr. Neal what he thought about the condition, and he said it was surely not a stroke. Moving on. Well, my disclaimer is trying to say, we're not talking about the law or your particular situation. If you need to talk to a lawyer, please do so. Just not right now. Okay, we're going to go through some cases. The first one that I want to start with is a situation involving a hospitalist. When I first started practicing, hospitalist medicine was not as prevalent as it is today, and it is virtually ubiquitous. We're going to talk about a lot of different specialties. I am not singling out my hospitalists. We're going to talk about a whole team liability. We're going to talk about lots of different individuals and how the liability spectrum affects them. But in this particular case, this case involved a 59-year-old mother of two adult sons who had been seen, was transported by a community hospital to a community hospital because of shortness of breath. That is a common fact pattern. That is a common fact pattern in Danville, in Martinsville, in everywhere. Once she was seen in the emergency department, there were indications that she had a potential pneumonia. The emergency department physician admitted the patient. They hadn't started yet a course of treatment or antibiotics, although often that does occur in the emergency department. But for whatever reason, this patient was admitted. A potential pneumonia was suspected by the hospitalist. Of course, with today's use of the electronic medical record, there was a severe allergy that was documented. One of the things that I encounter quite often in the medical record, and I review a lot of them, not as many as you guys do, guys and gals do, but I review a lot of them. And often allergies are documented. In this instance, the hospitalist selected an antibiotic, I believe received an allergy alert through the EMR system, selected the antibiotic regardless. Now, most of the cases that I've had, they override the warning because they don't believe that it was a true allergic reaction. Or they'll investigate it, pause, contact the pharmacist, and they will continue with that particular antibiotic. Unfortunately, in this instance, immediately, as soon as the IV antibiotic was started, the patient went into severe anaphylactic shock, did not respond to resuscitative efforts, and was dead within 7 minutes. A lawsuit was brought. If your faces were here, I would take a vote, or at least on site, ask people to raise their hands and say, what was the particular outcome of this case? So in the fact pattern here, we certainly have a physician who had encountered, was notified of a potential allergy, acknowledged that there was a potential allergy, and elected to administer the medication anyway. As a medical malpractice defense lawyer, it's my job to determine whether or not the care that was provided was consistent with the standard of care. And what the standard of care means is what a reasonable and prudent physician would do under the same or similar circumstances. So, is it reasonable for the attending hospitalist to override that electronic alert? The outcome of this particular case was a $900,000 settlement. I suspect that the defense attorneys who were defending this case could not find a supportive expert who was willing to say that the care provided was reasonable. Here we've seen a $900,000 settlement reported, but if we go back to the facts and we consider some of what happened, there are other areas where there are potential liability issues. For example, why wasn't the hospital named? Well, the hospital provides an EMR. The EMR in this instance provided an electronic alert. Okay, so did the hospital have an expert that said that their care was reasonable? Probably. But what about the pharmacist who was filling that prescription? Now, there's a few different ways that medications can be pulled. Was that medication readily available? Did it have to be mixed by a pharmacist? But if it was a pharmacist mixed medication, the pharmacist would have been confronted with the same alerts on their system. They would have seen what the acknowledgement was. Did that occur? If it occurred, there is a potential area of exposure with respect to the pharmacist. Multiple cases I've encountered have involved pharmacists filling prescriptions, realizing a potential allergy, contacting the physician directly to confirm that the override was intended, as opposed to just clicking through alerts. Click fatigue is as real as alert fatigue. When there's too much going on, there is too much going on, which is why I have a 3-minute delay whenever I send emails. Sometimes I type too fast. Moving on to our next case. The next case involves emergency medicine. Emergency medicine cases are very, very common, and for obvious reasons. Physicians are in a position where they encounter a patient that they have very little information on. Sometimes that patient is unable to convey information. All of the diagnostic tools are not available. In this particular case, a 30-year-old patient presented to the emergency department, and I put down here a 6-year-old son, and that's important for later for the outcome, with 10 out of 10 abdominal pain, sweating, cramping hands, unable to breathe, vomiting, screaming in pain. And yes, I know the pain scale, and 10 out of 10 is screaming in pain. And by all accounts, this individual was screaming in pain during the time he was in the emergency department. He reported marijuana use the prior day. Now that's significant because the later defense was that the symptoms of the patient were consistent with cannabinoid hyperemesis. However, during the deposition of the doctor admitted that he did not have cannabinoid hyperemesis documented on his differential diagnosis. Well, that's true. It probably wasn't. It's an unusual thing to include every single item in your differential. That testimony was also presented to the jury, which I think eroded the defense somewhat. Well, this patient had initially come in on the fast track process, Zofran labs, IV fluids, hydrate the patient. The physician extender who saw the patient determined, you know what, let's get the physician involved, got him before the physician. The physician in this case documented that they performed a complete evaluation, including an abdominal exam that was normal. From a factual perspective, the only other witness to these events was the patient's girlfriend, who denied that any physical exam had occurred. No imaging was ordered of any sort. No abdominal x-ray, no CT scan. The physician documented that the nausea and vomiting was of uncertain cause. And before labs that had been ordered were obtained, the patient was discharged. Those labs were abnormal. Now, the defense, the physician disputed that. The physician claimed that he was aware of the lab information, but the electronic records did not support that claim based on the way that they were reported. The patient was discharged with 8 out of 10 pain. The physician said if I had known it that the pain levels were that high, I would not have discharged the patient, even if I had previously made the decision. 10 hours after discharge, collapsed and died from duodenal ulcer. The outcome of that case, as you can tell by some of my presentation on it, was a verdict for $1.4 million. Now, as we talk about verdicts in Virginia, if you were not aware, Virginia has a medical malpractice cap, and we're going to go into some later details. But the numbers that you are going to see today are all going to be less than the cap, except for one. There's been one of the issues that we're going to talk about is recent pushes to change the medical malpractice cap or abolish it altogether. We'll discuss some of those in more detail. But as we're talking about some of these numbers and values, I'd like you to just hold some of this information in your mind and what stands out to you as a consistent pattern with the value of these particular cases. Okay, our next case is a general surgery case. By the way, almost every case that we talk about today, I have encountered in some way, shape, or form. Maybe not the exact specific fact pattern, but the issues that are involved, the particular treatment that was involved. This particular case involves a wonderful gastroenterologist who performs a colonoscopy on a patient, and during the procedure identifies a 4-centimeter precancerous polyp. Now, that's significant because the gastroenterologist is not going to perform a polypectomy during the procedure, so he marked the location with ink and also placed an endoclip. Now, the gastroenterologist then referred the patient to a general surgeon. The general surgeon performed surgery, a laparoscopic hemicolectomy, removing a portion of the bowel, putting the patient back together. The pathology from that procedure came back, and in the pathology, neither the polyp nor the endoclip were identified in the tissue. Now, that was not reported to the patient. It's unclear whether or not the surgeon reviewed the pathology report from the procedure. It's unclear whether or not the gastroenterologist who referred the patient reviewed the pathology report from the procedure. A year later, a new colonoscopy identified both the polyp and the clip. A second procedure was performed. The polyp was removed as well as the endoclip, and thankfully the polyp was identified as benign. What was the value of this case? In this particular case, it was a $300,000 settlement. So when we think about liability cases, there are going to be multiple drivers to what the value of a case is. Often it is the age of the patient, the significance of the injury, and whether or not there was any real harm that was associated. I am quite confident, I don't know the attorneys that handled that, but I am quite confident that the defense put on by the defense attorneys was, in essence, no harm, no foul. The polyp was later identified and removed. $300,000 settlement, I'm not sure if that's consistent with that particular fact. I'm quite confident that they did not find an expert to say that the general surgeon had satisfied the standard of care. But for whatever reason, the case ultimately resolved at that $300,000 level. Not to or to stick with the aspects of pathology, the next case involves the interpretation of pathology. In general, when we see pathology cases, they tend to obviously involve the misdiagnosis of cancer is the most common result from a pathology case. In this instance, a patient had been seen by an otolaryngologist for a persistent tongue ulcer. Now, that treatment ordered by the provider was a course of steroids. After the completion of the course of steroids, it returned, a biopsy was performed, and the pathologist identified that as a benign condition. On follow-up, the otolaryngologist reported that result to the patient, and the patient relied on that result, did not seek further treatment. Now, what's unclear is whether or not the patient's tongue ulcer or abnormality continued to persist. Unfortunately, I don't have perfect facts on all these cases. These are reported verdicts. By the way, all of these reported verdicts have been within the last 9 months in 2025. Also, most verdicts and or settlements are not reported at all. Many are subject to confidentiality agreements which prevent their reporting. So there is a large swath of data that is simply not available. Some cases will go to verdict, but before those verdicts are reported, the parties resolve, subject to a confidentiality agreement, effectively taking it outside of the range of data to understand whether or not there was a plaintiff's verdict or a settlement. Defense attorneys proudly report every defense verdict we get. We won't be seeing too many of those today in this pile, although there are quite a few that are out there. Anyway, back to this particular story. For whatever reason, 18 months later, a biopsy with a different otolaryngologist identified invasive cancer with suspected lymph node involvement. That resulted in partial tongue removal as well as 65 lymph nodes. The patient experienced nerve palsy and additional speech therapy was required for the patient. And the basic claim was, if I had been diagnosed sooner, procedures could have been done earlier, which would have minimized the impact on me. Not that obviously the pathologist didn't, nor did the first otolaryngologist cause the patient's disease, not in the slightest, but you prevented me from treating it. This case resulted in a settlement of $900,000. So as we think about case values and settlements, our prior case involved a settlement of $300,000. And in that case, it was the failure to remove a polyp, resulting in probably a completely unnecessary resection of a portion of colon. And the damages were likely as a result of you took something out that didn't need to come out, as well as needing a second surgery. So the cost of both surgeries is considered part of the patient's damages, as well as any pain and suffering associated with the procedures. But with this particular procedure, or with this particular lawsuit, what we can see is how this patient was injured affecting the recovery. So a larger tongue resection was necessary. Spread of the disease, or more importantly, the required harvesting, maybe not the spreading of the disease, of 65 lymph nodes. Nerve palsy, facial surgeries often result in nerve injury, particularly lymph node harvesting along the face and neck with the multiple nerve structures that are present there. And the need for speech therapy is not surprising. The cost of those procedures is a recoverable element of medical malpractice damages. A second recoverable element is the pain and suffering of the individual. A third recoverable element is the embarrassment, the humiliation, the scarring, if there is any, that may exist, the things that make you a different person. And the last one is whatever wages or lost income that you may have experienced. So this case resulted in a $900,000 settlement. I would estimate that the build cost of the surgeries was probably, and the total medical treatment was probably in the range of $100,000. That leaves $800,000 that was paid in other types of damages. What makes this particular case unique is that it was a physician. Specifically, it was an orthopedic surgeon who lost a portion of his tongue, who lost a portion of his ability to speak and required this procedure. So how long was he out of work? How did that affect him in the work environment? The next case that we're going to talk about involves the team itself. And this, I've encountered almost this exact case. This case was this year, so clearly wasn't. In this instance, there was a young patient who had experienced a femur fracture as a result of a car accident. At some point, it's unclear whether or not it occurred in the emergency department or if there was a closed reduction under anesthesia by an orthopedic surgeon, but he was casted by a provider. There is no documentation in the medical records of a vascular assessment being done. So that little nugget right there already tells you where this case is going to go. I can't tell you the number of cases that I've had that involve fractures or knee dislocations and subsequent vascular complications. And inevitably, it is the lower extremity and involves the popliteal, one of the popliteal vessels, leading to a loss of circulation, leading to ischemia, leading to the loss of a limb, usually the foot, sometimes below the knee, and once in a blue moon above the knee. In this particular instance, during the patient's hospitalization, the nursing team actually documented the inability of the patient to remove the toes on the left foot and that the foot was cool. There's a red flag right there. The nursing staff is actually documenting a problem with the patient. Were the physicians reviewing the notes of the nursing staff? Probably not. Were the nurses conveying the information to the physician about the condition of the foot? Probably not. If there are notes by the nursing staff that says, advise physician of patient's inability to move his left toes and cool foot, the liability for the nurse goes way down because they've taken steps to advise the physician. Okay. If the physician assesses the patient and says, I've assessed the patient's cool foot, still has feeling, I can feel pulses, I took a Doppler, yada, 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 that potential for liability goes way down. Because what we have is a problem and we have a response. And is the behavior, is the response reasonable? For the nurse, the problem is reported. For the physician, there is a response to the problem that has been reported. Well, in this instance, the patient was discharged after a 3-day hospitalization in a cast and returned 9 days later with left foot ischemia. I think the toes had turned black by this time. I'm not exactly sure. I'm pretty sure that they had. Imaging had identified a popliteal artery occlusion, surprise, and the patient's left foot was amputated. So looking at those facts, there's a multiple cast of providers who were probably named in this particular suit. For confidentiality reasons, the report doesn't tell me, but I'm going to guess the hospital on the basis of the employment of the nurses who documented the patient couldn't move the toes in a cool foot. I'm going to guess the attending hospitalist, if it was an ED physician who performed the casting, the ED physician, if it was an orthopedist, the orthopedist, for the failure to document a vascular assessment, the hospitalists for either the failure to respond to documented instances of the inability to move the toes and the cool foot, or the improper response to those signs and symptoms. The outcome here, a settlement of $1.5 million. So already we've got a spectrum now of settlement values, 300,000, 1.2. We got some verdicts, 1.4, and a settlement of 1.5. Whoops. Sticking with our orthopedic surgery theme, I've handled quite a few orthopedic cases. Because of my background, it's a particular area that I enjoy working on. I mentioned, you heard Dr. Moore mention that I was in the Navy and I was a nuclear chemist. Well, as part of that training, I was a mechanic. So basically anything that's sophisticated carpentry, I enjoy. So this particular case has a lot of lessons that can be learned. This was an 84-year-old nursing home resident who experienced a femur fracture. This is the bread and butter of nursing home cases. It's either pressure ulcers, or it's a fracture, or a subdural hematoma. That is what happens, and inevitably Coumadin is involved in that process. Well, she was taken to the hospital, and an orthopedic surgeon placed an intramedullary nail. Great, fine. Exactly what I would have expected. 3 months later, that patient experienced a subsequent periprosthetic fracture. Also not uncommon, also occurs. However, in this particular instance, the surgeon attempted a repair with a tibial plate. It's unclear exactly why, but a tibial plate was used to try and repair the fracture. Unfortunately, the fracture did not heal properly. The patient never regained the ability to walk and subsequently passed away at the facility. What was the result here? And there's a typo here, so I now see it. It says settlement. It was not a settlement. It was a $500,000 verdict. Okay, let's get back here for a second. Age of the patient is often a driver. An 84-year-old nursing home resident is probably not moving around a lot. And so the movement and the ability goes into those pain and suffering issues that often drive verdicts. But in this particular case, there was another set of complicating factors. This surgeon did not respond to the lawsuit, even though this surgeon had been served with the lawsuit. That placed the surgeon in a position of default, meaning you cannot answer the complaint. That rarely happens. It rarely happens because what should occur whenever any of you receive any legal papers whatsoever is you should immediately contact your insurance carrier. Immediately contact your insurance carrier. That is the most important thing to do, period. Because once those papers are received, a clock starts. And in Virginia, it is 21 days to file an answer to the complaint. The failure to provide an answer can put you in default. And that's what happened here. Now, why did this particular surgeon go into default? I would say he didn't report it to his carrier, but there was another complicating factor. After these events, which occurred approximately 2 years before the lawsuit was filed, sometime after this event, the surgeon stopped practicing. And when the surgeon stopped practicing, they did not continue to carry insurance coverage. Now, the surgeon has a claim that gets made, but has no tail coverage, meaning no coverage for things for today, for things that have happened in the past. That is the tail coverage. So the surgeon was left without insurance coverage, and it's the insurance provider who usually retains counsel. So in this particular set of circumstances, At the very end, after filing a motion for default judgment, somehow the court allowed the surgeon to make an appearance, I believe on behalf of himself with no counsel present. A small trial was held on damages only that resulted in this verdict. I have to say that if this case had actually been tried, I think the verdict would have been, well, when I mean actually tried, I think if all the evidence regarding the course of treatment had come in as opposed to just what the outcome was, I think the verdict could have been much higher, in the sense that juries often get upset if there is a case that they believe is indefensible, that is defended. Now, if a case gets taken to, sometimes there are cases that have to go to trial, but those cases can often result in the jury being very frustrated because they believe the facts are obvious. The plaintiff's attorney took the position that the use of hardware that was meant for a different part of the body was absolute negligence. But those particular facts didn't come into play. Instead, what came into play was the costs of the surgery, the cost of the second surgery, the cost of the first surgery, the cost of the second surgery, and the fact that she had passed away, and how that the death was not caused by the procedures themselves. So the damages here were limited to that small
We gotta
window,
go.
that small area.
Hey, Neil, there's a question
Yes.
in the chat, if I can interrupt you. It's from Dr. Lippum. Forgive me if you plan to mention it, but how would his case have been different if he had occurrence-based insurance?
If he had occurrence-based insurance? Well, that's a great question. Occurrence-based insurance, I have to tell you, hold on. There's claims-made based insurance, which is based upon when the claim is made. And if you are within the coverage window, meaning you're currently covered whenever you make the claim, you're fine. You're covered for that particular instance. Occurrence-based, if I remember correctly, is when you actually pay for coverage during a particular period of time. Therefore, if you retire, even though an event happened in the past, it is not, it's still covered by your insurance carrier. If I remember right, occurrence-based insurance policies tend to be more expensive because the length of time following the procedure or following the incident and when the statute of limitations expires can result in continuous exposure for the insurance carrier. Don't quote me on that, and remember, nothing today I say constitutes legal advice. Any other questions? Okay, we're going to stick with orthopedic surgery. This particular case, remember, we've already talked about some of the circumstances that that create value in cases. Age of the patient. In this particular instance, it was a 47-year-old patient who was into things, skateboarding, hiking, kayaking, fishing, very much an active person. And of course, active people tend to break bones. In this instance, broke a hip skateboarding, which is why I gave up skateboarding many, many years ago, as well as motorcycle riding, although I do still snowboard, which is probably going to present me with problems in the future. But regardless, this patient was injured skateboarding. The orthopedic surgeon performed a surgical repair, intramedullary nailing, rod and screws. However, shortly after the procedure, the patient said, "My foot's pointed inward. I don't think this is right. I don't think that this shouldn't be this way." Over the recovery course, no physical exams were documented. It automatically creates a he said, she said. If it's not documented, it's very difficult to say you performed the examination, particularly if the particular testing results in quantifiable information. There were no gait exams done to see how the patient was able to move. And the patient in his deposition said consistently, "I told the doctor about this problem. I told the doctor I was having difficulty moving about, that I just wasn't walking right." A subsequent consult indicated that there was a 30-degree malrotation of the femur right along that nail. For whatever reason, just twisted. It was clinically obvious, is what the consulting physician had reported. That required a surgical revision, essentially removal of the hardware, sawing the bone in half, twisting the leg, replacing the hardware, and putting the patient back together again. Since the facts of this particular case, since the injury, the patient has been able to move, gets around better, does not have the malrotation issue, but has ongoing pain and discomfort and scarring, and hasn't been able to get back to the hobbies that were enjoyed previously. Not that after that fracture, they would have been able to get to them, but have essentially having to go through it twice, certainly the surgery twice, has precluded him from participating. And that's part of the evidence that would have been introduced, that if the first surgery had been done properly, then the patient would have recovered in a more normal fashion, not in a perfect fashion. And that as a result would have been less injured. Again, the surgeon didn't cause the fracture, but the surgeon didn't put the patient back together properly. The result of this case, a $1.2 million settlement. So, again, younger patient, activity, probably the driver there. Because the surgeries themselves, probably a total of total medical expenses there, maybe, and again, this is billed, not paid, would be $150,000. Maybe a little higher, maybe 200. Depending on the nature of physical therapy and so on and so forth. Not a case that would require a lot. The bills would obviously be high. Depends on the length of hospitalization. Could be as low as 100,000. Really sort of depends on the circumstances. So the real recovery, the real driver for this settlement, the value is the youth, the youngness of the patient, the activity level of the patient. And that's when we think about it, it's the long-term impacts on a situation often drive the verdicts. We're going to talk about the malpractice cap in a bit and why those long-term impacts and how those long-term impacts are causing people to advocate for changes. Our last orthopedic surgery case involves a spinal fusion for a patient using extreme lateral interbody fusion at L3 and 4 and L4 and 5. Now, during the procedure, neuromonitoring was used to avoid or to warn the surgeon of the proximity of nerves during the procedure so that they would avoid nerve injury to the patient. And lo and behold, post-surgically, this patient was unable to move her left leg in the immediate post-operative period. Now, that progressed to being numb from the hip to the knee. Ultimately, the patient was able, through physical therapy, to be able to walk with a cane or a walking stick. She had been previously more active, a big walker, a much more active lifestyle. But because of the loss of nerve sensation in her left leg, her gait was significantly damaged. Now, the plaintiff alleged, and this is interesting, that the surgeon should have been aware of the anesthesia being utilized by the anesthesiologists, and that course of anesthesia was inappropriate because it resulted in a decreased response to the neuromonitoring equipment. In addition, during the deposition of the spinal surgeon, he admitted that he had never read the manual for the neuromonitoring equipment that was being used during the procedure. I'm shocked. I've never read the manual on my car. I've never read the manual. I don't think I've read the manual for anything that I have in the last decade. Maybe more than that. So, but regardless, he testified that he had not read the manual for that. So we have a few different sort of things at play in this particular case. One is the decision-making of the spinal surgeon. Was that appropriate? And the two claims there were, hey, you should have been aware of the anesthesia being used and how that would affect the neuromonitoring equipment. And two, you should have read the manual. Now, many of you may be asking, well, if you're going to talk about the anesthesia, the surgeon doesn't usually select that. It's usually the anesthesiologist. So shouldn't the anesthesiologist have chosen the right anesthesia? Can't tell you. Don't know. Don't know if that claim was actually made and those providers settled out under a confidentiality agreement. So I suspect, reading the facts here and the way the case is laid out, I suspect that that is the exact case that was brought by the plaintiff's attorney. It was brought in a twofold manner, one against the spinal surgeon and two against the anesthesiologist. You used the wrong stuff, you should have known he was using the wrong stuff, and you didn't read the manual. And that was their overall arching theory of liability. Now, did their experts cave on the anesthesiology side, or did anesthesia settle out? Or did they just realize their case wasn't good? I don't know. We will never know. But looking at this case and the way things have happened, I would suspect either they decided to drop anesthesia or anesthesia settled out because there was a potential that the anesthesia was inappropriate. Sorry, don't know the answer to it. Not familiar with the particular anesthesia that was used, nor am I familiar with the neurological effects that anesthesia would have on the particular nerves there. So we now have a single physician defendant who went to trial, and the outcome of that, congratulations, we have another defense verdict in our pile today. Kind of not surprising, expecting the orthopedist to control the anesthesia. I don't think that was reasonable. And I think the reading the manual argument sort of didn't hold a lot of water. I know that the defense experts, or the defense was able to put on experts that say, yeah, you're trained to use the neuromonitoring equipment, and there are no special alerts about using the neuromonitoring equipment, particularly with this set of anesthesia. So I suspect that was what was the driver. As I understand it, the verdict was returned by the jury within an hour. Our next case involves a gastroenterologist. Last time we heard about our gastroenterology friends, they had identified a polyp. They passed the case along to a general surgeon. This case differs. In this case, there was a 57-year-old male patient. And again, look at what we're talking about here, 57. So not 35, but also not 85. That patient was being followed for hepatitis B, which was very stable. Antiviral medications were providing the appropriate treatment. The gastroenterologist was regularly following labs. The patient's condition was well controlled. A liver function panel was then returned, and the gastroenterologist interpreted it as converting the disease to an inactive form of the virus. He elected to stop antiviral medications. A few months after stopping, the patient had an acute exacerbation leading to liver failure. The plaintiff's argument in this case was, one, it was inappropriate to stop at this point. You needed more testing and more confirmation. But two, that if you were going to stop, and there's literature that says that stopping can be appropriate, that you had to follow a more frequent monitoring regime to ensure that no damage was occurring and that there wasn't an indication to begin treatment again for the patient. So, outcome here, $2 million. Settlement. So, for whatever reason, if they couldn't find defense experts or the risk was too great, it was settled out. Our next case involves providers that are often on the forefront of very high exposure claims, obstetricians. And the issue there, it really dials into what we've continued to talk about, which is the age of the patient. Newborns are our youngest and most serious claims. The hope of new children really is a big driver in those claims. It's a traumatic experience for the family and can result in horrific injuries to the infant. In this particular case, a expectant mother was at 39 weeks. It was her second child. An on-call OB was the one responding when the patient arrived. Throughout the day, once she had been admitted for her labor, there were repetitive decelerations. The nursing staff communicated with the obstetrician and asked to evaluate. She identified dilatation with an anterior lip, was able to push the lip over the baby's head during the contractions. The head was fully delivered after 2 contractions. At that point, a shoulder dyssocia was identified. A McRoberts maneuver was attempted. Gentle downward traction was applied, not suprapubic pressure. Gentle downward traction was applied to relieve the anterior shoulder. There was no shoulder movement. They attempted a corkscrew maneuver, which failed. But during this process, the left arm was delivered. The posterior arm was stuck and was stuck there for a minute. On delivery, I'm going this way, it was actually the right arm. On delivery, there was no right arm movement. There was a diagnosis of a C8 nerve avulsion. Graft surgery occurred 13 months after the baby was born, and physical therapy continues with significant disability. Now, it is very common for these cases to be defended because obstetricians that encounter these complications are confronted with a variety of emergency situations. This case went to trial and resulted in a verdict for the infant at $3.3 million. Now, the medical malpractice cap for this particular event based on the time was $2.4 million. All right, so we've talked a little bit. This is our gateway into talking about the Medical Malpractice Act and the medical malpractice cap. So $2.4 million was the cap. That means that this verdict of $3.3 million, which was designed to compensate this infant for pain, suffering, humiliation, potential lost wages, inability or decreased ability to move the arm. That verdict of $3.3 million that was determined by a Virginia jury of 9 persons unanimously based on the evidence was cut to $2.4 million right off the top. So $900,000 right off the top of the verdict.
Neil, we have
Yes.
a question in the chat from Dr. Pandya. Please explain the role of the MSV in advocacy for malpractice cap. Thanks. I've served on the MSV for more than 30 years as the president in 2017.
Absolutely. So the Medical Society of Virginia is a significant advocate for maintaining a medical malpractice cap. In fact, we're going to get to some points that are occurring, but it is the leadership of the different organizations in Virginia, whether it's the Virginia Hospital System, whether it is the Medical Society of Virginia, and a whole host of other healthcare-related organizations are consistently lobbying and advocating and pushing to prevent Virginia from turning into an uncapped state, which has a whole host of problems. To keep medical malpractice insurance premiums lower, but simultaneously to provide a fair level of compensation for injuries. Fair is always in the eye of the beholder. So that's one of the big challenges with this whole process. And as our society moves forward, different individuals, different entities, different political organizations advocate for changes to that regime. Here in Virginia, it started, it went the wrong way. In 1975, when the General Assembly asked for a study regarding the increase in medical malpractice insurance rates. And that study determined that there was a 1,000% increase, and I forget the time frame, I believe it was from 1960 until 1975, 1,000% increase in medical malpractice insurance rates. As a result of that, the General Assembly passed the Medical Malpractice Act with the intent of lowering the costs of insurance and turning Virginia into a more attractive state for physicians to practice in, because they would be able to afford insurance. They know that their assets would be protected in the event of excess verdicts, and let them know that there was a place that provided certainty with respect to liability. Simultaneously, to turn Virginia into an attractive market for competition among insurance carriers, resulting in further decreased premiums. Several different statutory mechanisms were implemented in the Medical Malpractice Act, some of which still exist, some of which have been changed. But what we're talking about today is the medical malpractice cap. Now, that was initially a $1 million cap. Over time, that has changed. In 1999 and in 2011, we have different increases in the cap. The current cap is a rolling malpractice limitation, which increases by $50,000 a year. Injury today would be $2.65 million. Now, the cap applies to the date of the injury, which is why when we look back and we think about that, the infant case was 2.4 million. If you go back, that tells you that it was done sometime before July 2020, 2 years earlier was when that baby was experienced injury. The cap is going to continue to increase till 2031, and there's legislation in place which puts the final number to be at 3 million. I mentioned that things change and different people advocate. At the conclusion of the 2024 General Assembly, the stakeholders were asked to find a solution for the outlier medical malpractice cases. And what are the outlier medical malpractice cases? Those are the infant injuries with a $3.3 million verdict. Those are the traumatic cases that involve significant injury, loss of limb, paralyzation, inability to perform normal functions, high damages cases involving lifelong medical care, stroke, severe stroke, aneurysm, so on and so forth. Those outlier medical malpractice cases. So there's been a work group that was ongoing, and we talked about the Medical Society of Virginia. Different stakeholders have been involved in trying to investigate and get ahead of this. Now, bear in mind, there's the healthcare side. There is a whole extra side that as a significant motivation to remove or modify the cap for larger recoveries. And the most common thing that is heard is the Virginia Trial Lawyers Association, or the American Association for Justice, which is a gathering of plaintiffs' attorneys. And they take the position that people who are injured should be entitled to their most full recovery. And those different and there are other organizations as well. I don't mean to single them out. That's the other side of the bar, and that's the side of the bar that I'm most familiar with working with. They are organized and advocate for those particular outcomes, and are very successful in different states. They pursue it under a variety of fronts, whether it's claiming that the constitutionality of a cap is in question because it denies equal protection under the law and may violate the federal or state constitution. Some states have followed those. Virginia has not. In fact, caps have generally been upheld in the states that apply them. And I can't remember how many have them. I think it might be 14. Did not check on that. But there are other varieties of caps. We'll actually touch on that briefly. Anyway, that leadership group reviewed the liability survey done by the AMA. They got feedback from different medical associations and professional associations across the country, because it's different everywhere. I'll just give you a quick preview. It's different in North Carolina and Tennessee than it is in Virginia. It's different in DC. It's different in Maryland. There are different rules depending on where you go. I have to admit, I think Virginia's is the best. I think Virginia's is the most fair. I practice in 3 states, Tennessee, North Carolina, and Virginia. And in comparison to all those states, I think with respect to how the outcomes for plaintiffs occur, I think it's the most fair for all parties involved in Virginia. I'm a little biased. That's just me. In addition, they talked to professional liability insurers and consulted with an actuarial consultant for assessment. I hear a question. Is there a question? Maybe not. Okay, I'll keep going.
May I make a comment about the cap?
Yes, please do.
Thank you. This is Bhushan Pandya. I've been part of these negotiations for a number of years and wanted to point out that in Virginia, there is a bad baby bill that in cases
We're going to get there. We're going to get there.
Okay. Okay.
I want you to chime in if I say wrong. Okay?
Okay. Thank you.
I want you to chime in a second if I say wrong. This investigation determined that the cost of healthcare insurance per provider would be 11 to 13% if it was purchased at $2.6 million. And as we know, we have a rolling cap that increases. So that exposure would potentially change. It did not. It also talked about how costs would increase if providers had to elect for personal additional insurance coverage. The hard cap is great because that extinguishes all liability. And I'm going to tell you what, in Virginia, I have not run into a case. Well, I actually have. I'll mention that in a second. It is uncommon to run into a case where an individual provider and or practice group and or hospital is not insured up to the cap. Right? It's uncommon. Now, I have encountered it with some different providers that have come in from out of state who operate under the de facto $1 million. As you can see, the key takeaway, uncapped states, usually $1 million. But the results of this actuarial survey didn't include a whole lot other than the anticipated increase in cost. Now, this last point, uncapped states usually only have coverage of $1 million for individual providers. $1 million. So all of these cases that we've already talked about that settled at values of higher than $1 million creates potential issues. Does it increase or decrease potential settlement values? I have a colleague who practices in Georgia, uncapped state. They all carry $1 million. Leads to potential personal exposure for the individual healthcare provider. Results in a lot of bad faith litigation. Does it drive more settlements at a higher average value? Difficult to say. An actuarial assessment would need to be performed. I don't know how that data would turn out. I just don't feel like it's a very positive environment. I think our Virginia's hard cap system is very, very effective. So there was an effort to repeal the cap for all plaintiffs under the age of 10. That did not pass. There's been some directive that we need to resolve the catastrophic cases for adults and minors. Expect more action on that particular front. I expect that to happen. Now, I mentioned that we were going to talk a little bit about some other values, and I hope you have those verdicts and settlement values sort of in your head. I'll go over it again. The low was $300,000. The high was $3.3 million. That was reduced to $2.4 million. All right. But here's some sample not medical malpractice, meaning uncapped verdicts here in Virginia. $11 million for a tractor trailer crash with a traumatic brain injury. A suspect fleeing police with a traumatic brain injury, $2.75 million. Traumatic brain injury following a crash with a steel beam. In that instance, somebody was driving and actually ran into a steel beam. $6 million settlement. A logging crane operator death after the equipment collapsed while he was using the crane. $6.15 million settlement. A truck failure leads to a 90-year-old being in a wheelchair, $10.3 million, again, settlement. A stroke following a bike crash with a delivery vehicle, a $5 million settlement. So the other side is pointing out these desperate settlements. These are settlements. These aren't even verdicts. These aren't runaway verdicts that we can say, oh, the jury went crazy. They were very upset about semi trucks on the highway. They were very upset about the police. These are settlement values. And so the plaintiff's bar will frequently point to the value of these settlements as saying, there's something wrong here. Those are the recoveries for reasonably parallel injuries are so much higher. That's the environment that's being faced. That's what the Medical Society of Virginia is being confronted with, is this type of information and data, a direct one-to-one comparison in Virginia regarding settlements and verdicts. And again, nothing had settled for even the cap in the cases that I've talked about. It was always less than the cap. Different states treat it differently. So in North Carolina, there is a limitation on non-economic damages. Non-economic damages is pain and suffering. It's that whole bucket of things that are you being upset. Upset, in pain, PTSD, all of those different pieces and elements. It was originally $500,000, and every 3 years they're directed to adjust it for inflation. And in the 10 years, I believe, 9 years since the legislation was passed, it's at $656,000. There is no limit on economic damages. So if you can present evidence of your medical expenses being $250,000, great. If your ongoing life care plan to provide care for the injured individual is, and this is where some of the evidence gets outrageous, $2.5 or $3 million. And I'm going to tell you, in that obstetrical case, the life care plan for that would have been $5 million if it was anything, based on the amount of care needed for that particular individual, as well as potential lost wages. Now, in infant cases, lost wages claims are almost impossible to make because you don't know what somebody's going to become, nor that their limitation will minimize them from being able to be successful. We know that just as an anecdotal matter. But when you have somebody who was a high wage earner, such as a doctor, such as a lawyer, such as an engineer, and then suffers an injury and is unable to work at the age of 40, and they're projected to work until the age of 65, 20 years times X $100,000, immediately results in very, very, very high numbers. And in North Carolina, all of those economic damages are recoverable. It's only pain and suffering that is capped. Tennessee has a two-tiered system for limiting pain and suffering damages, $750,000 or $100,000 if it's intentional or a loss of limb or catastrophic. Also no limit on economic damages. Georgia is uncapped. Maryland is similar to North Carolina. It was started at $650. It's currently at $905. And DC is uncapped. So, we are an island surrounded by different approaches to limitations on medical malpractice verdicts. If you don't participate, if this is important to you and significant to you, make sure you participate with your local organizations, such as the Medical Society of Virginia. Find out, talk, help out, and try and advocate. That's my one extra side tip for the day. So there's been some other recent changes on the civil liability spectrum. One bill was going to deny protection of the Medical Malpractice Act if there were certain sexual acts that occurred in the course of treatment. This This legislation was inspired by some cases that occurred in Virginia, one of which, the most significant one that I can think of, was one of which occurred in the Tidewater area. It was a patient who was receiving, in that particular case, it was a patient who was receiving medical care while she was in an inpatient rehab facility. The patient, while she was present, was ultimately sexually assaulted by one of the employees and filed suit. They filed suit against the employee as well as the employer, which was the hospital, and sought very, very high damages. So one of the things that I mentioned very early on in this was the concept, one of the points I mentioned was the concept of respondeat superior, and that is the employer is liable for the actions of the employee. It's a vicarious liability theory, and in many instances, it results in the most fair result for the injured party. And here's the example. If a semi-truck driver ends up running someone over, obviously the driver of the truck was not driving properly. But the driver of the truck may have no insurance and may have no assets to pursue. So any verdict obtained against the driver is unlikely to be satisfied. Respondeat superior says, well, the person that employed the truck driver should be responsible for the liability, because no business can conduct any business without its employees. A business does nothing. There is nothing that a business does. It's the employees that do everything. They do everything for the benefit of the business. And that theory of liability, vicarious liability, is a fair result for the injured person, because now the truck driver who has no money, who may have no insurance or very limited insurance, now that passes through to the employer. And that's a reasonable system. It's used throughout the United States and in many other countries, because obviously if you're doing the work of your employer and you mess up, your employer should have responsibility for that. But what happens when the employee isn't doing what you hired the employee to do? And the Tidewater case is exactly that. There is no hospital on the planet that hires someone to sexually assault patients. It doesn't happen. Why then should the employer be responsible for the actions of somebody who goes out of their way to engage in criminal activity? Should the employer be responsible for that? I recently wrote an article, and the article that he mentioned, that was that Dr. Moore mentioned, that I won an award for, was on this topic, and ultimately on a statute that we're going to talk about. Ultimately resulted in a debate between the defense bar and the plaintiff's bar as to whether or not this liability should be changed under certain circumstances like this. But in general, when an employer has an employee who engages in actions that are so far beyond what they hired them for, well, then they deny that they're responsible for the actions of the employee. It did not hire the nurse to engage in sex with patients, to sexually assault patients. Didn't do it. So we're not responsible for that. Now, there are other direct theories of liability that are always at play. Did you negligently hire that person? Did you have some other reason that you could have, should have, and would have known about this activity? Is there some other standard at play? Those theories of liability are direct theories of liability. But respondeat superior is a vicarious one. You don't have to do anything wrong. It just has to be your employee. You're just responsible for your employee. So the genesis behind this bill was that Utah utilized the approach that those actions weren't healthcare and couldn't be shielded by the Medical Malpractice Act, meaning they wouldn't be capped. because really in Virginia, that's the most significant. There's a few other elements to the Medical Malpractice Act, but the most significant one is that it wouldn't be capped. That statute did not pass. So this is an example of a law that was trying to carve out an exception to the med-mal cap. All right. Instead, what was passed was this law, which is the vicarious liability for certain victims, known as vulnerable victims. So the statute, this is what I was talking about earlier. Vicarious liability is liability for the employee, for the employer, should be, I apologize, for their actions. It ultimately results in the financial exposure of the employer. It directly attaches to their insurance coverage. It leads to liability exposure. And if they don't have sufficient insurance coverage, it leads to exposure for the company. The statute itself created a group of people that they called vulnerable victims. And this includes patients of a healthcare provider. Boom, right there, right there. Patients, I can't highlight it. Patients of a healthcare provider. People under a disability, we won't worry about that. That's like people in jail, stuff like that. Residents of an assisted living facility. Again, different type of patient, but also broadened out. Assisted living isn't just people in nursing homes. People in lighter duty facilities also applies here. Passengers of common carriers. Okay, taxis. There's some exclusions there. And then customers, this was very interesting to me, of aesthetic spas or massage therapies. Now, why did they put those there? I will tell you why those are there. Those are there because for some reason, massage therapists have a significant problem with engaging in sex with their clients. And so automatically, this law is going to apply to those situations. Now, what does it do? This law was passed. And actually, I participated in some of the discussions about the original law that was presented. And I say we very broadly because I was not involved in direct negotiations about this bill, but I was involved with reading the different versions and pointing out where there were issues. And the original version of the bill was absolutely terrible. I know people's eyes are glazing over because this is legal stuff. But it was terrible for employers because it resulted almost in what's called strict liability, which meant that if your employee did anything wrong, you were going to be on the hook for it, no matter how bad their actions. Somebody's got me on, it's got their microphone on. Do they want to ask a question? Nope. Okay. So under those categories, there were some reasons that we're gonna make the employer responsible all the time. So if the employee performed his action, i.e. molesting a patient, while they were in contact with a victim, this law should apply. If the employer failed to exercise reasonable care to prevent the harm, this law should apply. If the employer knew or should have known or had the ability to control, this law is going to apply. And if the employer knew or had the opportunity to control, this law is going to apply. And what that means is the employer is going to be on the hook when a vulnerable victim, one of these people, a patient, disabled person, assisted living, taxi, medical transport, aesthetics or massage therapy, is injured as a result of the actions of an employer. Now, it doesn't talk about sexual assault directly. It doesn't talk about those things because employers don't deny liability for the actions of their employee when the employee is doing their job. It really applies to things like sexual assault, stealing something from someone. It's more broad than healthcare. This goes into everything. It's got taxis here. Mugging somebody in your taxi, shooting someone. any sort of harm that occurs to these vulnerable victims automatically may make the employer liable. Well, it doesn't automatically make them liable, but it means you can't file motions in advance of trial to say, good gosh, judge, sleeping with patients isn't what we hire people to do. Shooting our taxi customers is not what we hire people to do. A judge can no longer strike the vicarious liability claim. There are no pretrial motions. It has to go to the jury. What's it going to mean? I don't know. I'm actually presenting on this topic at the end of October in front of the Virginia Association of Defense Attorneys with a fellow panel of really good defense lawyers beyond just healthcare, where we're going to talk about that. The position I took in my original article was that this issue was always, at the very earliest, was never a pretrial motion, was always an issue that needed to be resolved after all the evidence came in. It did not, my position was it did not require a jury. If there was no evidence, appropriate evidence by the plaintiff's side, a judge could strike it, but only after the conclusion of all evidence. This statute tweaks that a bit and says, no, it's always got to go to the finder of fact, which would usually be the jury, unless it's a bench trial, then it's the judge. So that's my statutory update. If anybody has any questions or wants to add anything on that, there were a whole lot of different statutes that, candidly, Scott Johnson, who is a part of my firm, who regularly advocates before the General Assembly, has a whole presentation on that. I just took some pieces and parts that more directly apply to healthcare providers. Any questions? Man, I'm going to use up all my time. Yeah, go ahead.
Well, Mr. Lewis,
Yes.
thank you for a wonderful presentation. This is Bhushan Pandya again. So I hope you agree with the following statements I would like to make. One, that when somebody is served with a claim of malpractice, I understand that you, the defense lawyers, usually say it's not about your competency or your professionalism, it is more about money. And so it's a civil suit. It is to claim money for the damages, and it's not for putting you to jail. And so I think the first response for any provider should be that, okay, let me look at this and not as a challenge to my professionalism. The second comment I wanted to...
Doctor, can I interrupt? I'd like to answer that real quick, because you got hit on a great point, and I want to address it, and we'll go to your next one. Okay. Just yesterday, I spoke with two different physicians who had never been involved in a claim before. Both of those physicians were very, very concerned about the process. Now, in that instance, they were only being asked for a deposition, but that doesn't matter. The specter of litigation creates a stressful environment for every healthcare provider, from doctor down to nurse's aide, down to, I've even got cases that involve the people who do check-in at the hospital who have no healthcare training whatsoever and are literally registering people. It is a stressful environment. And that statement was absolutely correct. Lawsuits are about money. That is always it. It is about money. All right. If an individual wants to try and question your competence at all, that forum is often done through a complaint to the Board of Medicine, which, by the way, if you receive any communication from the Board of Medicine, you should immediately notify your insurance carrier. You may have insurance coverage to deal with that situation, and I cannot tell you how many providers have tried to provide a response without understanding the significance of what was being asked of them. Either they put it in a drawer and forget about it, or they fire off a quick response because they feel offended. Contact your carrier because you probably need some assistance. But let me rewind and get back to this issue about civil suits being about money. That's what they're about. I have a lot of respect for our civil system because it is the very thing, our rule of law is the thing that keeps us from punching each other in the street whenever we have a problem with each other. It is the recourse for every person that feels aggrieved. It's one of the most notorious things about the American system that I'm going to sue you if something happens. But what you don't hear is, I'm going to shoot you. Well, maybe you do these days. I don't know. But it really, the knee-jerk reaction is file a lawsuit to protect your interests. And people understand that. And that creates a society that works together, a society that understands no matter how aggrieved you are about the situation, if you need a solution, that solution is monetary. When you first are involved in a lawsuit, a lawyer should reach out to you and answer all your questions and hopefully walk you through this process. And if you want to know, you need to ask. Okay, that is so important. Okay, please continue. I apologize.
Thank you. The second point I wanted to make is that the challenge to the cap is usually or almost always mainly made by trial lawyers. And we are talking about money. I don't know what percentage. You heard all those big figures and whether they get 30%, 50%. So while they are concerned about their clients, they also, it's their livelihood and it's a big livelihood. Now, these laws, this protecting the cap or not, is made by our legislators. And you know how elections go and how money is important for elections and all that. So while the trial lawyers are able to contribute to their political action committee in millions, doctors, if at all, through medical society and others, reach about 100,000, 150,000, 200,000. So just imagine how difficult it is to win in a committee in a legislature, in Virginia legislature or anywhere. So it is important that if we want to have a fair policy and law to protect us, we need to advocate. And the way to advocate is to contribute. So it is very important to be a part of the process rather than take its consequences. Thank you.
Absolutely. Absolutely. Any other questions before I move on to the most hated topic in America right now?
No questions.
Okay. I'm going to go through these really quick because as everybody knows, we don't know what we don't know. But I'm going to blaze through a couple of little issues that I want to point out to you, and I just want you to think about if you encounter them. The first one is AI transcription services. I know some providers right now who are utilizing those, especially in their private practice, to help streamline their documentation. They carry around a little pod. That little pod basically hears their entire patient interaction and crafts a note for them. Different medical record systems may allow for the same type of service. I don't know exactly. There's hundreds of different tools that are being used. At the end of the day, your note is your note. You need to know your note. You need to read your note. You need to correct the typos in your note, which you aren't doing, by the way. I just want to let everybody know you're not correcting your typos. I can't tell you how many women are admitted as a men or vice versa, or the right leg or the wrong leg. Correct, read, own, because that's your note, and you're going to need to own it. I don't even want to get into on the issue of whether or not that particular service is HIPAA compliant. We're not going to talk about that. Own your note with these AI transcription services. There are AI radiological interpretation tools, and particularly in mammogram, and probably soon in other areas. I know that those systems can be dialed up or dialed down with respect to their sensitivity, but at the end of the day, you have to own your diagnosis. You have to own your diagnosis and not absolutely rely on those tools. I know it goes without saying, but I mention it anyway. I've actually got a case right now that touches on that. In AI robotic assisted surgery, robotic surgery has become incredibly popular and is incredibly useful for a variety of different patients. Okay, but as those tools are being used, there may be issues that are encountered. Make sure you understand the equipment and how you're going to use it and how it's performing, just as if you were using a normal tool in a surgical procedure and you know something's not right. Stop, pause, figure it out. I mean, if you can, of course, you're in a surgery, for gosh sakes. Um, Tough to say what's going to happen with respect to some of these different tools where you can set a surgical field, but then the instrument goes outside of it and results in injury, or you set particular levels. I see those as being device type claims, not particularly physician decision-making claims. That's just we see that already with technology, with anything that we use, whether it's electrocautery and what the settings were at, or any particular a neuromonitoring tool that's used during a spinal surgery. AI mental health support. Well, right now, this is getting the worst review of all time from all of the different articles that I am reading. Now, I know that there are specific mental health support AI tools that are out there that are designed for mental health, but I also understand from several different articles that these chatbots are not necessarily staying linear in their thinking and are not being helpful. Now, those are not necessarily designed for mental health support. But be wary of the tools that you may be using. Diagnostic assistance, it's the same with radiological interpretation. At the end of the day, the diagnosis, if it's reasonably within your scope of practice and an AI tool makes a different diagnosis or makes the correct diagnosis, but you select a different one, why didn't you select it? You need to be able to identify and understand that. Or if it makes the wrong diagnosis, why did you go with it when the other correct diagnosis was staring you in the face? Your clinical discretion, judgment, decision making is the most important tool that you are educated and trained on. Remote monitoring, this is beginning to become in vogue on telemetry units. We already have remote telemetry monitoring. Well, we've already got all the bells and whistles that happen for every different pulse oximetry and heart rate and interpretation of EKG. I expect this to continue to try and computerize tasks that can be labor and alarm intensive. How successful will that be? I don't know. Chatbots and virtual health assistants, those are often going to be directed to the individual. I have seen and heard of some providers already having them at the front end of their initial office visit practice or an initial request for communication, much like my Apple service was last week on my device. I don't know how successful that is. And at any point when a patient-physician relationship is established with a chatbot, but you have no actual control or potential any information at all unless a summary is sent to the patient's medical record, I feel that could lead to a particular area of exposure if an individual provider's name is attached to it, because they are expected to review it and determine if the clinical decision-making of the chatbot or virtual health assistant was correct. The key issue always is who is going to be responsible for the decisions, but from the liability perspective, who is going to be responsible when something goes wrong? And I am 59 seconds from my 1 hour and 30-minute presentation. Are there any questions? Can I get a round of applause?
Any questions?
Anything else?
Any questions for Mr. Lewis? Neil, thank you for doing this. I really appreciate your including the AI material. Sometimes the providers may not realize the AI is part of the EMR that they're dealing with. You have to be sensitive to that. And it's really just to reinforce something. It's a red herring if a legal issue comes up and you go back and look at your note and that note has a lot of typos, that immediately indicates it wasn't proofread. And, so you just can't be too careful about this. And again, I know we have some hospitalists on the call. We have a lot of residents. Every day of that progress note, when you're on service that day, you are responsible for what's happening that day. So you've got to check, double check, and be sure that, basically when you have a dictation, when you sign that dictation, you're saying, I'm willing to go to court with this. And that's what it really means on a practical basis. We're a little late in our hour, but we told Mr. Lewis to, make sure he covered what needed to be covered. Are there any final questions? We won't belabor and hold people on the call. Any final call questions? Okay, well, thank you so much, Mr. Lewis, for doing this. Also, thank everyone for being on the call this evening. I hope you will rejoin us next Thursday night when Dr. Frank with Dr. Cooper will talk about the appropriate use of blood products. So try to have a good night this evening. It's getting cold outside. It feels like winter's coming and the leaves are beautiful. So take care. Bye-bye. Thanks so much.
Bye-bye, everybody.